Nephrotic syndrome. Nephrotic syndrome is a clinical state that includes massive proteinuria, hypoalbuminemia, hyperlipidemia, and edema. This is very important for you guys to know. So when it comes to nephrotic syndrome, we're going to see massive proteinuria, lots of proteins in the urine. Are we ever supposed to see protein in the urine? No. Hypoalbuminemia. Well, albumin, guys, we know is a part of the blood, right? But we don't have enough of it. It says hypoalbuminemia. And we know that albumin portion of the blood, that protein portion of the blood, isn't that what keeps the fluid in the vessels? Yeah, so think about what happens when there's not enough of the albumin. Let's keep going. Hyperlipidemia. So patients going to have what? High cholesterol, lots of lipids in the blood, right? And edema. Of course they're going to have edema. If the patient has hypoalbuminemia, not enough albumin, and we know albumin is the protein part of the blood that keeps the fluid within the vessels. Whenever that albumin is low, the fluid that was supposed to be in the vessels, they go, woohoo, party time, we are out of here. And they leave the vessels and go into the tissues, and that's what causes edema. On top of kidneys not working properly, but let's keep going. So guys, this disorder is characterized by increased glomerular permeability to plasma protein. Remember, plasma, this is a type of protein, and it results in massive urinary protein loss. It's that protein that was keeping the fluids within the vascular space. Pathophysiology. Patients with MCSN, that's your minimal change nephrotic syndrome, are twice as likely to be male. The pathogenesis is not fully understood. The glomerular membrane, normally impermeable to albumin, that word, when you guys see that word permeable, that means to be able to get through, right? The glomerular membrane, normally impermeable to albumin and other proteins, becomes permeable to proteins, especially albumin, that leak through the membranes and are lost in the urine. We're seeing this again, hyperalbuminuria. So it's low in the blood because it's all lost in the urine. Make sure you guys are reading very carefully, guys. Patients got hypoalbuminemia, but hyperalbuminuria. It's low in the blood because it's all being lost in the urine. This reduces the serum albumin level, hypoalbuminemia, decreasing the colloidal osmotic pressure in the capillaries. As a result, the vascular hydrostatic pressure exceeds the pull of the colloidal osmotic pressure. Look at this, causing fluid to accumulate in the interstitial spaces, causing edema. And body cavities, particularly the abdominal cavity, that's ascites. So basically, they got all this edema and swelling in the abdominal area. The shift of fluid from the plasma to the interstitial spaces reduces the vascular volume, hypovolemia, which in turn stimulates the renin-angiotensin system and secretion of antidiuretic hormone and aldosterone. You guys have to understand that this is not something you're going to be able to guess on the test. You have to understand what's happening, okay? Tubular reabsorption of sodium in water is increased in an attempt to, because it's trying to compensate now, in an attempt to increase the intravascular volume. All of the fluid that we had in the vascular space that's supposed to be going to the tissues to feed the tissues and cause perfusion, right? Because we're losing the albumin, that protein, all of the fluid shifts, all of the fluid leaves that vascular space and it goes out in the tissues. That's what's causing the edema. That's what's causing the ascites. And now we have these proteins that should have never gotten through the kidneys. Now it's spilling over into the urine. Where was I? Okay. The elevation of serum lipids is not fully understood. They can explain everything else, but with the lipids, we know the cholesterol is high, but we're not sure exactly what's causing that. But you need to know that. Hyperlipidemia. The lipids are going to be high where? In the blood, not the urine. Diagnostic evaluation. The disease is suspected based on the clinical manifestations. Those classic clinical manifestations, again, guys, is your hyperalbuminuria, hypoalbuminemia, edema, ascites, hypovolemia. Parents usually give a history of the child being well, but steadily gaining weight, appearing edematous, and then becoming anorexic. Well, of course, if they're holding on to all those fluids, I wouldn't want to eat either. Becoming anorexic, irritable, and less active. Next page. The diagnosis of MCSN is suspected on the basis of the history and clinical manifestations. Again, edema, proteinuria, hypoalbuminemia, and hypercholesterolemia in the absence of hematuria and hypertension. The hallmark of MCSN is massive proteinuria, higher than 2+ on the urine dipstick. We're never supposed to see protein in urine. We see that, especially when we're dealing with peds, we need to be thinking of nephrotic syndrome. The serum protein concentration is low. Well, of course it's low. It's not in the blood because it's all in the urine, right? The serum protein concentration is low with the serum albumin significantly reduced and plasma lipids elevated. Albumin in the blood is going to be low. The albumin in the urine is going to be high. And the cholesterol in the blood is going to be high. Therapeutic management. Actually, before we get to therapeutic management, for the millionth time, let's look at these clinical signs and symptoms we expect to see in the patient with nephrotic syndrome. Weight gain. They're holding on to all those fluids instead of letting them go. Puffiness of the face, facial edema. Abdominal swelling, that's your ascites. They're easily fatigued. Look at this. I should have put a star next to it. But the blood pressure normal or slightly decreased. Think about it, guys. And this is very interesting because usually patients holding on to all this fluid, we expect the blood pressure to be high because there's lots of fluid in the vascular space. But in nephrotic syndrome, that's not the problem. Yes, they're holding on to fluid, but it's not in the vascular space, it's in the tissues. So even though they're holding on to all this fluid, even though they're swollen, they got ascites, the blood pressure is either going to be normal or even low, which is something we really don't expect to see when patients are holding on to fluid, because normally when patients are holding on to fluid, the fluid is in the vascular space. But in nephrotic syndrome, it's not, it's out in the tissues. And so this is kind of something that makes it different than other disorders. So this should be a key to make you know, okay, whoa, we're most likely dealing with nephrotic syndrome and not something else. And that's why it said a hallmark of this is that blood pressure, it's not going to be high because there's not fluid in the vascular space. That fluid left, fluid's out in the tissues. All right, therapeutic management. This is exciting stuff, right? Why am I the only person excited today? That's killing me. All right. What's that? Exactly, this is good stuff. Therapeutic management. So dietary restrictions include a low salt diet, and in more severe cases, fluid restriction. They're already holding on to all their fluids, right? And we know fluids follow salt, but so you think they need to be having a lot of salt in their diet to hold on to even more fluids? Absolutely not. If complications of edema develop, diuretic therapy may be initiated. If the patient has an acute infection, they're going to get antibiotics. Corticosteroids are the ding, 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 first line therapy. Corticosteroids. Side effects of steroids. Before we even get to that, you guys know, off rip, if we're talking about steroids, the very first 3 concerns that need to come to your mind as a nurse If patients on steroids, we're going to be concerned about infection because they mask the signs and symptoms of infection. We're going to be concerned about hyperglycemia because it's very sugary and makes the patient's blood sugar high. We're going to be concerned about porous bones because it tends to make the bones weak and porous, right? And we're dealing with peds, right? Their bones are still growing. And the fourth thing, let me add a fourth thing to it because we always got to be concerned about ulcers. Steroids are very hard on the stomach, so we're going to be concerned about ulcers. Okay, let's see what they have to say now. Side effects of steroids include increased appetite, weight gain, rounding of the face, behavior changes. Long-term therapy can result in hirsutism. That's where, you know, they get those secondary sex characteristics. The girls might start getting, you know, facial hair, or the boys might start getting the male boobs. Growth retardation, cataracts, hypertension, GI bleeding, bone demineralization, infection, hyperglycemia. Been seen on NCLEX. Make sure you know these side effects. Episodes of MCSN, both the first episode and relapse, often happens in conjunction with a viral or bacterial infection. Relapses can also be triggered by allergies and immunizations. Relapses in children with MCSN can continue over many years. Keep them healthy. You want to prevent them from getting infections. Prognosis. The prognosis for ultimately recovery in most cases is good. Children who respond to steroid therapy, the tendency to relapse decreases with time. Nursing management. Continuous monitoring of fluid retention or excretion is an important nursing function. Strict INO records is important. Other methods for monitoring progress include urine examination. We're going to be checking the urine for albumin. We're going to be doing daily weight. Remember, guys, those daily weights, that is our #1 indicator to let us know how much that patient's holding on to fluid. It is not skin turgor, it's not INO, it's daily weight. Daily weight, we're going to be measuring their abdominal girth. We're going to assess them for edema. Check for increased or decreased swelling around the eyes, dependent areas, the degree of pitting, the color and texture of the skin. We're going to take vitals. Infection is a constant source of danger to Davenous children and those receiving corticosteroids. These type of patients with chronic infections, they need to be the first in line getting their vaccines, guys, and you have to teach that to the parents. The CDC, they recommend pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine for children with nephrotic syndrome. And what did I write down here? I wrote they are already immunocompromised, protect them from infection just like you would pneumonia and other diseases. Okay, you're going to help work with the parents to formulate a nutritionally adequate and attractive diet. Salt is restricted but not eliminated during the edema phase and while the child is on steroid therapy. Because steroids by themselves are going to have that child looking swollen. Fluid restriction is limited to short-term use during massive edema. Every effort should be made to serve attractive meals with preferred foods. And with the preferred foods, guys, you still have to stick under the guidelines of decreased salt. So a famous NCLEX question when they ask about child with nephrotic syndrome and they're giving you these choices, do not choose chips. Chips are high in sodium content. Suitable recreational and diversional activities are an important part of their care. Irritability and mood swings that accompany steroid therapy are not unusual in these children and may create an additional challenge for the nurse and family. Family support in home care. Parents are taught to detect signs of relapse and to call for changes in treatment at the earliest indication. Parents are instructed in testing the urine for albumin, administering medications, Providing general care. Parents are instructed on avoiding contact with infected playmates, but the child should attend school. But we have to do everything in our power to keep them healthy and away from people who are sick because they can't afford to get sick. All right, that's your nephrotic syndrome. Do you guys need a break before we move on to acute glomerulonephritis?
Yes.
All right, we'll take a break. 10-minute break.
How about the top? What if you like one on the top?
Oh, I wrote page 1057 to 1058. So when they're talking about suitable recreational and diversional activities, if you don't know what those activities are, we talked about them already, but if you forgot, refer back to page 1057 to 1058. All right, 10 minutes, guys. Sure, go ahead. Okay, guys, acute glomerulonephritis. Acute glomerulonephritis. Common features include oliguria. They're not urinating much. Edema. Look at this. Ding, ding. Hypertension. So if you get a question and you're trying to figure out if you're dealing with nephrotic syndrome or you're dealing with acute glomerulonephritis, well, guess what? With an acute glomerulonephritis, we have hypertension. You don't see that in nephrotic syndrome. Hypertension, circulatory congestion, hematuria. That's another thing you don't see in nephrotic syndrome. You don't see hematuria, but you do see this in glomerulonephritis and proteinuria. When you're studying, look at the differences so you can figure it out. Most cases are post-infectious and have been associated with pneumococcal, streptococcal, and viral infections. Acute post-streptococcal glomerulonephritis, that's APSGN. This is the most common of the post-infection renal diseases of childhood, and one for which a cause can be established in most cases. Etiology. NCLEX absolutely expects for you guys to know the etiology of glomerulonephritis. All right, so the APSGN, that's the acute post-streptococcal glomerulonephritis. Remember that, because from now on, I'm just going to keep saying APSGN. I'm not saying the entire thing. So APSGN. This is an immune complex disease that occurs after an antecedent streptococcal infection with certain strains of group A hemolytic streptococci. That you need to know. Most streptococcal infections do not cause APSGN. A latent period of about 10 to 21 days occurs between the streptococcal infection and the onset of clinical symptoms. So after that patient has been infected with that streptococcal infection, there's about 10 to 21 days before we start seeing those clinical manifestations of the APSGN, which is the glomerulonephritis that we're talking about, okay? Pathophysiology. The pathophysiology of APSGN is uncertain. We're not 100% sure. Immune complexes are deposited in the glomerular basement membrane. The glomeruli become edematous and infiltrated with I'm not even going to try to pronounce this. You guys see it. But anyway, that's where it goes to glomerulus, right? So I want you to understand what's happening. All of these big words are just basically saying the patient got infection with a streptococcal infection, right? You know, when you get infection, you make antibodies. They all go to the kidneys and they start to clump up. This is what we're seeing happening, okay? The resulting decrease in plasma filtration, because remember, they're clumping up in the kidneys. The resulting decrease of plasma filtration results in excessive accumulation of water and retention of sodium that expands plasma and interstitial fluid volumes, leading to circulatory congestion and edema. So not only do we have a whole bunch of fluid in the tissues, we also got it in the vascular space, hence the hypertension as well as edema. Diagnostic evaluation. Typically affected children are in good health until they experience a streptococcal infection. And this is why it is so important. That child has a sore throat. You teach the parents to stop trying to be cheap and not take their kid to get their throat swabbed because they don't want to pay not co-insurance, copay. Thank you. Because a simple 99-cent antibiotic from Publix can clear this up, or at least can decrease the severity. Let's keep going. Urinalysis during the acute phase urinalysis during the acute phase characteristically shows hematuria and proteinuria. So when it comes to this disorder, we definitely will see a blood in the urine and protein in the urine. Azotemia. Guys, this is increased urea nitrogen. This is what we're supposed to find in the urine, not in the blood. You know how the kidneys filter your blood and all the bad stuff, all the crap, the toxins that you do not need, it goes out in the urine, right? Now imagine that floating in your bloodstream. That's what azotemia is, okay? Azotemia, that results from impaired glomerular filtration, is reflected in elevated blood urine nitrogen, that's your BUN, and creatinine levels in at least 50% of cases. Cultures of the pharynx are rarely positive for streptococci because the renal disease occurs weeks after the infection. Circulating serum antibodies to the streptococci, and this is what I was explaining earlier, indicate the presence of a previous infection. The why did I even try to pronounce this? Mr. Scott. Oh, thank you.
Anti-streptolysis.
There you go, antitreptolysis. Oh, that's your ASO titer. This is the most familiar and readily available test for streptococcal infection. Now, take a look at the clinical manifestation for acute glomerulonephritis. You are going to be expected to know the difference between this and nephrotic syndrome. So, patient's going to have edema, anorexia. I wouldn't want to eat if I felt bloated and full of fluids. The urine. Look at this. The urine's going to be cloudy, smoky brown, resembling tea or cola. What do you think is causing the urine to be that color? The blood. Urine also is going to be severely reduced volume, and that's why the patient has oliguria. And towards the bottom, mildly to severely elevated blood pressure. Therapeutic management. Children who have normal blood pressure and a satisfactory urine output can generally be treated at home. Moderate sodium restriction and even fluid restriction can be instituted for children with hypertension and edema. Remember, that salt is going to follow the fluid. Foods with substantial amounts of potassium are generally restricted during the period of oliguria. Remember, guys, potassium has a very narrow therapeutic range, right? Anything outside of that can cause the patient to have dysrhythmias. This patient's not urinating. They're not getting rid of the potassium, so you have to be careful with that potassium intake. We don't want to cause that patient to have hyperkalemia. Regular measurement of vital signs, body weight, INO. Patient's going to be on antihypertensives and diuretics. Antihypertensives for the high blood pressure, diuretics to get rid of all of that fluid.
I think you did it a little bit.
Zoom in.
I think, yeah.
Is better?
Yeah.
Okay. Prognosis, almost all children correctly diagnosed as having APFGN recover completely, and specific immunity is conferred. So subsequent recurrences are uncommon. When you see that says immunity is confirmed, that means because you had it once, you'll never have it again, or it's very unlikely that you'll have it again. Nursing management. You're going to do vital signs, especially blood pressure, check the fluid balance, check their behavior. Vital signs provide clues to the severity of the disease and early signs of complications. The volume and character of fluid are noted, and the child's weight daily. Again, daily weight, that's your number one way to know the patient's fluid status. How much fluid are they really holding on to? The child with edema, hypertension, and gross hematuria, scroll up, and gross hematuria may be subject to complications and anticipatory preparations such as ding, 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 seizure precautions and IV equipment are included in the nursing care plan. For children, a regular diet is allowed, but it should contain no added salt. Foods high in sodium and salted treats are eliminated. Patient needs to avoid them. Parents and friends are advised not to bring snacks such as potato chips or pretzels. Like literally, potato chips is an example that they've asked on NCLEX so many times. Activities should be planned to allow for frequent rest periods and avoidance of fatigue.